more than 30 years. And how many sarcoma patients I treated. So I personally see around 200 new sarcoma patients per year.
Okay,
so
that's a lot.
Somehow I'll extrapolate how many in total I see, because it's the new patients are 200 per year. And of course, you have to somehow count the consecutive patients, in the follow-up treatment, etc.
Yeah.
But this is let's say, these are the numbers. How long I'm practicing, as said, so more than 30 years. Why you're interested in sarcoma? This was actually by chance. I tell you how this started.
Okay.
As you can imagine, in training, you are in the hierarchy very, very low. And my former chief somehow distributed the cancer entities to the other physicians, and I was the youngest. So you can guess, the first opted for, let's say, the big entities: breast, lung, prostate, colorectal, right? And the last entity, I was the last one and the lowest one in the hierarchy. Said, well, Thomas, you are now the sarcoma specialist. And this is how I started, to be honest. Yeah. I mean,
okay.
it was to be honest, it was very difficult, because at the beginning, I consulted, let's say, 5-6 patients a week, which is nothing, in comparison to now, and I have to somehow build up my credibility, my expertise, and I started to cooperate, and then it started like this, that in the country they say, okay, there is one guy who is taking care of sarcoma patients, and it grew and grew. So this was the beginning. The most specific thing about sarcoma, the problem is, it is as you probably know, it is a very rare disease. So and even it's more complex, because it is very heterogeneous. Take all sarcomas histologies, 100 different histologies. You say that 30 to 40 new cases per 1 million per year. So I think Bulgaria has the similar size of Austria. How many people? 9 million in Bulgaria, or 8 million in Bulgaria? How many live?
As per the last counting, we are 7 millions.
So 7 millions, which would mean in Bulgaria, you have around 280 to 300 new cases per year.
I think we have less, but unfortunately we don't have official statistics. So I cannot be sure how many patients we have. Sarcoma
because if you say 40 per 1 million per year, right? So 440, per 1 million.
Yeah.
And you say Bulgaria has 7 million, then it's 280. Let's say between 200 and 280 per year. And I mean, the symptoms depend on the location, right? You cannot somehow generalize the symptoms, because a sarcoma can occur everywhere. I've seen osteosarcomas on the ear, for instance. So every histology can occur on every location. However, there are some, let's say, predilection areas. We say, okay, because 2/3 of the sarcomas, they occur in the extremities. And this is in the lower extremities, followed by the upper extremities, followed by the trunk. And the symptoms depend on the location. When we're talking about the extremities, it's a swelling. It's a swelling, and when this tumor is close to a nerve, then it's pain. Quite often, this is mixed up with a hematoma. Still mixed up with a hematoma, but the hematoma is not growing consecutively, right? So this is not growing permanently. The hematoma is somehow shrinking and not growing. Yeah, but the symptoms cannot be generalized. So this depends where the tumor is located. And for instance, you have sarcomas in the abdominal cavity as well. So it's mainly the liposarcomas or the leiomyosarcomas or the solitary fibrous tumors you have in the abdomen, so in the retroperitoneum. And this depends where they are located. If they are close to a kidney, then they can compress the kidney and can cause pain in the back, for instance. If they are located in the, let's say, in the lower part of the abdomen, in the small pelvis close to the bladder, prostate, this can be associated with problems with urinating, for instance. Yeah, but this is, as said before, this is very hard to generalize. Yeah, what are the symptoms?
But some people said that in cases of bone sarcoma, there are no symptoms. They appear late when the tumor is so big that it's pressing the organs.
This depends, because the nerves are in the periost, yeah, and if this tumor is close to the periosteal area, there are the nerves can be associated with pain. Yeah, so. This is not given. Yeah, this is not given. This depends where the tumor is located in the bone. Yeah, is this in the middle? Is this superficial? Is this tumor located in both, let's say, compartments in the bone as well as in the surrounding soft tissue? Because some bone tumors have an extraskeletal part. Yeah, so extraskeletal part, which means the tumor is in the bone, but is somehow penetrating the so-called periosteal area, and infiltrating the surrounding soft tissue, so the muscles and the fatty tissue. So this is why it's hard to say.
Just to, can you lift a little bit your camera, because I'm not seeing your face.
Okay. No, it's better.
Thank you.
Yeah.
Thank you. So in what cases people should go to doctor and to suspect sarcoma?
It is a pain. It's
pain.
If
there is a pain,
or pain in the bones, yeah, and the lesion in the soft tissue which is permanently growing.
Okay.
Yeah.
Okay. And that is leading us to the next question. What is the most important part of the diagnostic process?
Yeah. So the most important thing is that from the beginning, the surgeon, it's mainly the orthopedic surgeon when we're talking about the extremity sarcomas, is involved in the planning of the biopsy. Because I tell you why. Because the surgeon has to know from where the biopsy was taken and has to know where is the biopsy channel. Because within the surgery, the biopsy channel has to be removed as well. And this is why this is so important, that the sarcoma surgeon is involved from the beginning in the biopsy planning.
Okay.
And there are, let's say, several two methodologies. This is three. This is a CT guided biopsy. This is an ultrasound. The second one is an ultrasound guided biopsy, but preferably a CT guided biopsy should be done. And occasionally, let's say, the dignity cannot be assessed with the CT guided biopsy. Then sometimes an open biopsy has to be done. When there is, let's say, insufficient material, the location is so, let's say, unfortunate that it cannot be accessed via CT guided biopsy, close to the vessels, for instance, then an open biopsy has to be done. And then
this CT. Sorry for interrupting. CT-guided biopsies are core needle. They are needle biopsies, right?
Correct. Absolutely correct. Yeah, absolutely correct. Core needle biopsies.
So you said that in general, the preferred method of biopsy is core needle biopsies, and in some occasions, yes, CT guided, yes, and in some occasions it would be made a surgical operation.
Exactly, yeah, but this is very rare, yeah. So let's say the vast majority of the sarcomas, let's say that way, is diagnosed via CT guided biopsy.
But in Bulgaria, the most common method for making a biopsy is open biopsies.
Yeah. Yeah. Yeah.
This is why I'm asking, I'm clarifying the first part, that you recommended the
CT guided biopsy. Absolutely. Absolutely.
Okay. Yeah. Okay. And what are the benefits of these CT guided biopsies?
It's easy. It's easy. It's fast. It's not a surgery. It's not anesthesia. Yeah.
Okay. And do the tumor react more aggressive to the open biopsies?
No. But the problem with the open biopsy quite often is then you do not only the biopsy, then they do the excision, then you have a OOPS procedure, yeah, because then maybe this tumor is somehow demanding a preoperative chemotherapy or radiotherapy. Yeah, so this is quite often what is happening in the so-called open biopsy. That the tumor is not only biopsied, it's taken out. Then the cavity is contaminated with tumor cells, which necessitates a second surgery, and then sometimes an amputation, because from the primary surgery, the cavity of the surgery is completely contaminated with tumor cells.
Okay. And after the biopsy, the next one is the treatment.
Now the next one is the histology. When you have the biopsy, this should be assessed by a sarcoma experienced pathologist, and then you have the correct histology, and then you can plan how to proceed further. And this depends on the size of the tumor, the histology, and the location of the tumor. If you do upfront surgery, or if you do a preoperative therapy, which can be a radiotherapy, which can be a chemotherapy, which can be both. This depends on the histology. Or you do surgery upfront, followed by radiotherapy, followed by chemotherapy, or only surgery if it's not an aggressive sarcoma. So this is why this histology, a reliable histology, is so important to have it upfront before you do any treatment. So the diagnostic part is one of the most important prognostic markers.
Yeah. Do you recommend a second histology report after we have the first one?
So, I mean, usually, I mean, I can tell you how it started in Austria.
Okay. Yeah.
So there are, let's say, two sarcoma pathologists. One of which is at the university in Vienna, and the other one is at the university in Graz. And I mean, Bulgaria is similar size, so there should be one or two pathologists in Bulgaria who you provide with all the materials, and they can gain expertise. When they gain expertise, then they are the future referral pathologists in Bulgaria. So I strongly recommend that from the pathology, one or two persons are identified in different locations. Who should assess all sarcoma specimens.
Okay, and now the treatment.
The multidisciplinary approach, this is so important, because this is so important that the surgeon, the pathologist, the radiotherapist, and the oncologist are sitting together, and are planning the treatment. This is so important in sarcoma.
Okay. Okay.
So what we have, that is called, because you say in the clinic I'm working in, So once a week we have a multidisciplinary tumor board with exactly. This is the orthopedic surgeon in this case, when we need an abdominal surgeon in abdominal sarcoma, then the abdominal surgeon is present, or thoracic surgeon. This depends on the location, but usually it's the orthopedic surgeon, it's the medical oncologist, it's the radiation oncologist, is the pathologist, and the radiologist. And they are sitting once a week, and so roughly, 20 patients are discussed, per tumor board.
Yeah. So this is very important part of the treatment, I suppose.
Yeah, absolutely. Not only the treatment, and even it's a diagnostic as well, right?
Yeah.
And in the follow-up, because exactly in the tumor follow-up, in the follow-up care, because when you do not know if this is a relapse or yes or no, you need a radiologist. This is why these patients are discussed in this tumor board as well. Not only the treatment and the diagnostic, let's say, patients, the follow-up patients as well. If something is unclear.
Okay. Okay. And since the sarcoma is so rare and is different in each and every person, maybe, is the personal approach in this process important?
You mean personalized treatment?
Yeah.
Okay. The immunotherapy, you mean, right? Okay. Unfortunately, there is no clear, let's say, biomarker, which has been identified so far to say or to state this sarcoma patient is benefiting from immunotherapy. It says some are. This is correct. I personally have a young patient with metastatic osteosarcoma. Who gets now the 100 cycle of pembrolizumab. But there is no clear biomarker established, which can be selected to identify the patients who benefit from the immuno.
But saying more general, the disease is not running the same with each and every patient, right? Meaning that two patients with osteosarcoma can have completely different approach or something.
So let's say in osteosarcoma, the approach is standardized. So in osteosarcoma, it is a preoperative chemo, surgery, postoperative chemo. In Ewing sarcoma, this is standardized as well. To have a preoperative chemo, surgery, postoperative chemo, and radiotherapy either before or after surgery. This is standardized. And in the soft tissue sarcoma, let's say there are some histologic subtypes which benefit from chemotherapy A more than chemotherapy B. Let's say that way. So, but and there are some histologic, let's say, sub-entities which are completely refractory to chemotherapy. That means the chemotherapy doesn't make any sense. So you have to do, let's say, a tyrosine kinase inhibitor, like the imatinib, sunitinib, etc., etc. So, but this depends on the histology.
Yes, and in cases of Ewing sarcoma, for example, some doctors said that it is highly intelligent because it is hiding from the chemotherapy, and suddenly it appears.
No, the Ewing sarcoma is chemosensitive. This is a chemosensitive entity.
Okay.
The Ewing sarcoma is extremely chemosensitive. But the osteosarcoma, this is 50-50. The osteosarcoma. But the Ewing sarcoma, what I see is, and my experience, this is a chemosensitive entity.
But I've heard some cases when they're applying chemotherapy and everything was fine. It is the disease is under control and everything is okay. And once the chemo stopped for a certain period of time, it appeared immediately at several places.
This depends. This depends. This depends on the so-called regression rate, because what you do is when you do a preoperative chemotherapy in Ewing sarcoma, then the pathologist is checking the surgical specimen in terms of the remaining vital tumor cells. So that means how many tumor cells were killed due to the chemotherapy and how many cells are vital. This is the so-called regression grade. This is 1, 2, 3, 4, 5, 6. And regression grade 1 means this is all tumor cells are dead. So this depends on this regression grade, where you say, okay, this is the very let's say patient is healthy, relapse risk very, very low. Or we have a pathologic specimen where the pathologist, well, okay, 90% tumor cells are vital. So this depends. So you cannot generalize this.
Can we say which type of sarcoma is has the biggest relapse rate?
So what is very aggressive is the so-called desmoplastic small round cell tumor, but this is an ultra rare disease. It's called the Ewing of the abdomen. It's not a Ewing, but it's a different tumor. This is a desmoplastic small round cell tumor. This is a tumor which is a very high relapse rate. And the other histologies, this depends. This really depends on the histology. But when you see one of the most aggressive is the desmoplastic small round cell tumor.
Okay. So in terms of let's get back to the treatments. Is there any new therapies, any innovative therapies that are available and that you're applying for sarcoma?
You have, when we're talking about chemotherapy, you have, for instance, the doxorubicin, the epirubicin, the ifosfamide, you have the trabectedin, you have the eribulin, then you have the Gemza and the dacarbazine, then you have the docetaxel, then you have, for instance, for angiosarcoma, you have the paclitaxel, you have the pazopanib, which is a tyrosine kinase inhibitor. Then you have for entities like the solitary fibrous tumor, you have the temodal, which is a tablet, plus the bevacizumab, which is an antibody. And then you have the imatinib, for instance, for dermatofibrosarcoma protuberans, and then you have the sunitinib, for instance, for. So you have, but in comparison to the big entities, this is a big difference. So in terms of the, let's say, availability of drugs in sarcoma, and one of the, let's say, largest problem is the off-label use. Because some of them are not in label, so you have to. This is my daily job to apply off-label. Because for some entities it's completely useless to apply chemo.
Yeah. And here we're reaching the point of clinical trials. Do your patients participate in some clinical trials?
Yes, the answer is yes. But what I know now, on the horizon, there are no, let's say, new treatments, what I'm aware of, except the one I've already mentioned before. Some new TKIs are tested. Combination TKI with the other targeted drugs. Immunotherapy is tested. But what I'm aware of, nothing, let's say, close to registration. Let's say it that way.
But how important is for some patients to participate in a clinical trial? Is this a benefit for them?
It is a benefit because they are, let's say, more closely monitored. Yeah, they are monitored more closely. Yeah, and of course they are contributing to new knowledge.
Yeah.
But the problem is the accessibility of these clinical trials. Yeah, this is the problem. Yeah. But
yes,
but what I recommend, because
problem.
because I don't know in Bulgaria, is there, let's say, one center who says, okay, we are the referral center of Bulgaria in terms of sarcoma, or not?
No, we don't have a specialized center. And I'm asking about clinical trials because in Bulgaria there is completely no access to any clinical trials in sarcoma. And that's why I'm asking how beneficial is it for the patients, because in some cases maybe this is the only treatment option.
Yeah, because the problem is, when you participate in the clinical trials, let's say the blood tests are done more frequently, the computer tomographies are done more frequently. That means the patient, the sarcoma patient, has to travel. Yeah. And if this is a once weekly, let's say, blood withdrawal, so the best would say, the best for Bulgaria would be that one or two, let's say, centers, say, okay, please send us the sarcoma patients, because then they can gain experience. They can gain experience, and then they will get the trials, because the more patients you have, the more attractive you are for the pharmaceutical industry. Because when the patients are spread all over the country, that you say, okay, this physician is consulting 2 sarcoma patients per year, the other one is 3 per year. But if you somehow focus on 2 centers, then they can say, okay, we have 100 patients per year. It's a completely different story. But somebody has to start with this.
Somebody has to start, and this is one of our top priorities to work with specialists to establish such a center here in our country. And what do you think about genetics in sarcoma?
Okay. Yes, it's an integral part of the diagnosis, because there are some sarcoma subtypes where you should do a so-called molecular pathology upfront, in order to say this is an alveolus of part sarcoma, for instance. This is a synovial sarcoma. This is a Ewing sarcoma. This is a myxoid liposarcoma, because all these types have a certain fusion which can be detected via molecular pathology testing, or epithelioid hemangioendothelioma. This is important, the upfront molecular pathology. And this is again what I said before, that's 1 or 2 pathologists in Bulgaria should start with this. Usually it's the Archer fusionplex, it's the panel which is tested in sarcoma. It's called Archer fusionplex. And this is done in parallel to the morphology, and this is done in parallel to the immunohistochemistry. And quite often it's the argument, this costs too much. There are so few patients. We are talking about 150 patients per year, what we said before, right? Or 200. This is nothing against breast, lung, colorectal.
Exactly. Exactly.
So let's say the argumentation cost, I think, is invalid for sarcoma, because it's a rare disease.
But at what stage do you think it is recommended to make this genetic testing? As part of the diagnostic? Or?
Yes, exactly. Upfront. As part of the diagnostic. It's the molecular pathology. The molecular pathology, that means the tumor cells, are tested via, or NGS is the same, next generation sequencing molecular pathology. There are sarcoma panels. Yeah, this is sarcoma panel. It's the archer fusion plex, and they are testing for these specific fusions.
Because some doctors are making genetic testing when the patient is not is showing resistance to the treatment.
Yeah, but this is another testing. This is a therapeutic testing. But I'm talking about the molecular pathology upfront in order to identify the correct histology. What you are talking about is the genetic testing, the therapeutic panels. Yeah, but this is, to be honest, I think this is not of help in sarcoma. Because quite often there is in these reports, they said, okay, this is a fusion CDNK2A or whatever, yeah, and then they say, well, there is a drug available somewhere in the world which is tested by this company, but what they do not tell is that you don't get this drug because the pharmaceutical industry is not giving this to you. And this is, I think, this is unfair. Yeah? This is extremely unfair. The pressure from the industry, I know. Yeah, they do the marketing via patients. Yeah, and yeah, the expectancy of the patients, yeah, with this molecular testing is so high. Yeah, and the likelihood that, let's say, a fusion is low. And it's even lower when you identify this fusion or mutation that you get the drug for this.
Okay.
I'm talking about the genetic testing, upfront molecular pathology, diagnostic, not therapeutical.
This is the most important one.
Exactly.
The diagnostic one.
Exactly.
Okay, so I have a few more questions, and the first one is a bit more sensitive about the survival rates of your sarcoma patients. Can you share your views, your information?
But this depends on the histology, because there are 100 different histologies. If you have a highly differentiated liposarcoma, the cure rate is 100%. So this depends really on the histology. But if you say, okay, you take all histologies, from the soft tissue sarcoma, I'm talking about the soft tissue sarcoma histologies. You say, okay, 2/3 they will make it, and 1/3 won't make it. But this is not serious because we are talking about so many histologies. When we are talking about Ewing sarcoma, you can say that 60–70% will survive it, and are cured. When we're talking about localized disease, not metastatic, localized. Yes, localized disease. Yeah, and in osteosarcoma, it's around 2/3, 3/4 are cured permanently.
Okay.
In metastatic disease,
about localized.
In metastatic disease, it depends on the histology as well. I tell you an example. I have patients with metastasis from an endometrial stroma sarcoma, highly hormonal receptor positive. They are living for 10, 12, 13, 14, even 20 years. This depends on the histology. And then I have patients, of course, with metastatic disease. They won't survive 6 months. So this is very, very, let's say, an inaccurate measurement to say, okay, sarcoma.
So I agree completely.
This depends on the histology.
Okay.
But usually in the papers, let's say the median survival, they say it's 4 years, 3.5, 4 years, But this is so unreliable because we're talking about many histologies.
Yeah. And you cannot compare pears with apples.
No.
You have
exactly.
to have
exactly.
You have to have a certain criteria. Okay. And what type of patient are you treating? Do you treat children?
No.
You're only adults.
18 years plus. 18.
Okay.
Sometimes 17. I tell you why, because when you start with the chemo, they are 17, and when you stop with the chemo, they are over 18. Yeah. This is why 17, but this is rather an exception. Because when the children are treated in Vienna in the children's hospital, in the St. Anna Children's Hospital.
St. Anna. Yeah. I know it. But still, I wanted to ask you about children.
I'm not allowed to treat children.
Yeah. Okay. And is it possible sarcoma patients from Bulgaria to come to your hospital for a treatment?
Yeah. The problem now in the hospital is because they are not insured in Austria. This is the problem. Mm-hmm. Yeah. But what is possible that colleagues are contacting me, which they are doing, yeah, because some Bulgarian doctors are contacting me how to treat. Yeah, this is possible that the physicians are contacting me. Yeah, this is what is happening actually. I'm contacted from Bulgarian colleagues. Yeah, but the patients, yeah, personally, is telemedicine as well, yeah, but this is via my private practice, so I cannot advocate for my private practice. Yeah, this I do. Okay. Yeah, but in the general hospital where I'm working, legislation currently that patients who are not insured in Austria cannot be consulted. Yeah, this is the legislation.
The patient should be insured in Austria. Yeah. To have exactly. Possibility to be treated. Okay.
Then a consultation can be done, but this is not easy. But
yes, for sure.
Yeah. But the physicians can contact me.
Okay, this was very interesting and important information.
Yeah, the physicians, and they are doing this. Yeah, they are doing this. Yeah.
This is very good.
Yeah.
Okay. Yeah. And my last question is, at the end of our conversation, can you say something positive to the people who are fighting with this disease?
Positive about the families. Yeah.
It seems hard.
Yeah. No, I understand. You can live with sarcoma, even with metastatic disease.
It's not a death sentence.
No.
Okay. This brings hope.
Yeah.
So people should get used to it. Thank you very much once again for your time.
Yeah, sure. Yeah. And but the best, believe me, would be some 1-2 centers start to generate expertise.
Yes.
That now we start, and sarcomas, and the others are, let's say, admitting the patient to this 1 or 2 facilities, and they are starting to generate expertise.
Yes. I believe in this as well, so that's why we are working in this direction to find the best place to make it here.
And the pathologist as well, orthopedic surgeon, radiation oncologist, and medical oncologist.
Yeah. Okay, thank you very much.
It was the same in Austria. Yeah. Nobody took care. They were spread all over the country.
And how did you change this?
Yeah, we started. I said before. When I said, you do it, okay, I do it.
So but who was
there has
the leader?
To be a strong, there has to be one strong personality. Yeah, female or male, it doesn't matter. Yeah, a strong personality who starts with this.
Okay. I take it personally as a test.
Oncopolitics.
Yeah.
Yeah, but
sure.
It was the same in Austria. It was completely the same.
But how many years ago it was?
30 years ago, when I started.
30 years ago. Yeah. But now you have an expertise.
Yeah, but it takes time. But somebody has to start.
Yeah. That's why it was so interesting to hear from you, from your point of view.
Because it's not easy. I tell you why. Because from the, let's say, big entities, breast cancer, lung cancer, colorectal, there are thousands or 100,000 of patients, 100,000 of papers. So don't misunderstand me, but it's somehow easy to treat. Yeah. Because you can read this paper, this treatment recommendation, these guidelines. So this is not very difficult to treat.
Yeah.
But don't misunderstand me. So, but sarcoma is not easy because you cannot read. There are no papers. I mean, there are some papers, but you have to generate personal expertise that you can say, okay, in this entity I tried this. This was the outcome. Let's do it that way. It's not easy. It's not attractive. Because you have to spend time.
And to collect all the cases at one place.
Exactly. And you have to spend time on every single patient. You have to spend time. It's more. It's difficult. In breast cancer, okay, you see estrogen receptor positive, wonderful surgery, and aromatase inhibitor, like this. It's not very difficult. In comparison to, let's say, orphan diseases. And this is let's say the hurdle up front that let's say that way that somehow prevents somebody care on sarcoma because it's time consuming, especially in the beginning.
How many sarcoma specialists do you have in Austria?
We have let's say 2 big hospitals. Where you have the pathology, the radiology, the radiation oncology, the surgeon, and the medical oncologist. This is one of which is in Vienna, and the other one is in Graz, which is the southern part. And then you have in Linz, you have experienced medical oncologists. But again, this has to somehow grow. You have to start from somewhere. Somebody, strong personality, who has influence in politics, in oncopolitics, has to somehow start with this. It's time consuming, but it's worthwhile because in 10 years, you will see this will work out. But somebody has to start.
For sure. Okay.
All right.
Thank you very much once again.
Sure.
And maybe it's at a later stage I can contact you with some other questions.
Okay. Do this.
Be healthy and have a nice day.
The same to you.
Thank
All
you.
the best.
Bye.
Bye-bye.